Okay, so I'm going to be speaking today on the main role of MRI in adults with congenital heart disease. I don't have any financial conflicts, but I will discuss the use of gadolinium chelate contrast agents for a cardiovascular MRI. So the learning objectives today are to list some congenital cardiac anomalies that can be evaluated in adulthood, to describe postoperative complications in adult congenital heart disease, and to understand MR assessment and diagnosis of adults with congenital heart disease. So what are some of the more common indications for MRI of congenital heart disease? These are some of them that we do in our institution. Tetralogy of Fallot evaluation, especially in the postoperative setting, transposition of the great arteries, and coarctation of the aorta. So Tetralogy of Fallot has several features. Of course, there are 4 lesions, and they include a VSD, an overriding aorta, pulmonary stenosis, especially at the infundibular level, and right ventricular hypertrophy. So the surgery for Tetralogy of Fallot involves closure of the VSD as well as augmentation of the right ventricular outflow tract. And if the RV outflow tract or infundibular stenosis is not severe, if it's mild, then infundibulectomy can be performed. In moderate to severe outflow tract stenosis, then in many patients there is a transannular patch repair. And right ventricular to PA conduit can also be done, especially in the setting of a severe stenosis. So when do we use MRI? Usually in the postoperative setting. And what we want to evaluate is right ventricular enlargement, especially the end diastolic volume. We assess for residual and recurrent right ventricular outflow tract obstruction, pulmonary regurgitation, which is a relatively common complication of the RV outflow tract surgery, branch pulmonary artery stenosis, which can be seen preoperatively as well as postoperatively. Sometimes we see left pulmonary artery kinking in the postoperative setting and residual or recurrent VSD. So these are the various features we should be assessing. So this is a patient with right ventricular enlargement. You can see how large the RV is. And this can be quantified using the steady-state free precession Cine MRI. Now, as I said, pulmonary regurgitation is a relatively common complication after surgery for Tetralogy of Fallot, and it's important to assess the severity. In older children, and especially in adults, it can be difficult to use echocardiography to assess the right ventricle, and in that situation, MRI is ideal. So we can interrogate the pulmonary artery, and we do it at our institution just distal to the pulmonary valve. This is the pulmonary valve location, and we interrogate here using the velocity-encoded Cine MRI phase contrast technique. And you can see on the left side here we have a magnitude image, on the right is a phase image of the phase contrast. And the pulmonary artery is here, and it shows dark signal indicating forward flow and bright signal indicating regurgitation. And this is quantified. This flow curve shows forward flow during systole and retrograde flow during diastole. And if we take the retrograde volume and divide it by the antegrade volume, that equals the regurgitant fraction. In this patient, it was about 42%, which is moderately high. And this patient, because of this moderate regurgitation, as well as large end diastolic volume of the RV, the patient underwent pulmonary valve replacement. As I mentioned, pulmonary artery stenosis occurs in Tetralogy of Fallot. It can occur preoperatively as well, and we can see the right pulmonary artery is stenotic here, and we measure blood flow in the right and left pulmonary arteries, and these are the flow curves. The right pulmonary artery blood flow is substantially diminished compared to the left because of that stenosis, and this can be treated using angioplasty and stent. MR can also be used to assess the prognosis in Tetralogy of Fallot, and I'll just have a few words on this topic. We assess right ventricular myocardial fibrosis, and delayed enhancement indicating RV fibrosis is associated with a poor prognosis in tetralogy. Another marker of poor prognosis is decreased left ventricular ejection fraction. So when the left ventricle starts to have diminished function, then that suggests that the patient will have a poorer prognosis. So this is an example of delayed enhancement in which there is a delayed enhancement in the right ventricular outflow tract. And again, this myocardial enhancement suggests fibrosis, which indicates a poor prognosis. Let's move on now and talk about transposition of the great arteries. I will talk primarily about complete transposition. In this entity, the left ventricle connects to the pulmonary artery and the right ventricle connects to the aorta. Usually, transposition of the great arteries is assessed preoperatively using echocardiography, and we use MR usually in the postoperative phase. And what we are looking for in the arterial switch procedure, we look at the anatomy and specifically assess whether there is a pulmonary artery stenosis centrally. In the baffle type procedure, mustard or setting, we assess right ventricular hypertrophy and enlargement, stenosis or thrombosis of the baffle, as well as a baffle leak. So this diagram indicates the normal anatomy with right ventricle to pulmonary artery connection and left ventricle to aortic connection. Aorta is back here. Whereas in transposition of the great arteries, the right ventricle connects to the aorta and the left ventricle connects to the pulmonary arteries. In transposition of the great arteries, we may see the aorta directly anterior to the pulmonary artery, as we see in this patient, and alternatively, the aorta may be slightly to the right as well as anterior to the main pulmonary artery. And as we scroll down in this patient, we can see the aorta anteriorly and the pulmonary artery behind. And the aorta is connected to the right ventricle, so it's coming out of the RV, and the pulmonary artery comes out of the LV, and that's the complete transposition. Notice that the right ventricle is enlarged. We can see displacement of the septum towards the left. And there's also right ventricular hypertrophy, and that's because this is an adult with transposition, and this patient has undergone a mustard procedure in the past with the baffle right here. So because of this mustard baffle procedure, the right ventricle is pumping the systemic circulation, and it can start to dilate and fail over time. And we need to assess whether the baffle is patent. In this patient, we can see that it's patent. And it turned out there's no stenosis or thrombosis in the baffle, which is a good result. Now, these images show another patient with repaired transposition of the great arteries. And notice how large the right ventricle is with right ventricular hypertrophy as well as enlargement. And we can see the baffle over here. And that is patent without stenosis. Now, as I mentioned, it's important to assess baffle leak. We see in this patient there is a baffle leak here with a jet. It's a left to right shunt in this particular patient. So that's another complication of repair of transposition of the great arteries. Now, the more modern type of surgery, which is an arterial switch or Jatene procedure, this has been around for about 25 years, or approximately that, 25 years. So patients who are younger than that age will probably have had a Jatene. Older patients will have had a mustard or setting procedure. Now, Jatene procedure involves placement of the pulmonary artery anterior to the ascending aorta, and the pulmonary artery straddles the aorta. So the left and right pulmonary arteries are on either side of the aorta. And one of the complications of this is that there can be proximal pulmonary artery stenosis as a consequence of compression by the aorta, just because of the location of the pulmonary arteries and the way they drape over the ascending aorta. In this situation, the patient might need an additional surgery. This particular patient had to have another surgery to relieve that proximal pulmonary artery stenosis. Let's move on now and talk about coarctation of the aorta. The role of MR is to assess the site severity and extent of narrowing. We can also evaluate functional significance using velocity-encoded cine MR, the phase contrast technique, to measure pressure gradients and collateral flow. In the post-operative or post-treatment setting, we can measure change in collateral blood flow. We can identify recurrent coarctation as well as patch aneurysm. So this is an MRA of a patient with coarctation. This is a gadolinium-enhanced MRA showing a discrete juxtaductal coarctation. In this patient, we can see profuse collateral vessels. The coarctation is here. We can see profuse collaterals. On the movie, you can see them here. Okay, so we can quantify the functional significance of coarctation. And one way to do that is to measure the pressure gradient. And we can do a velocity-encoded cine MR phase contrast study in this plane. This is the candy cane or oblique sagittal view. The coarctation is right here, and we see abnormal flow distally. So we measure the peak velocity. We identify the peak velocity. And in this patient, it was approximately 210 centimeters per second, which is 200 meters per second. Using the modified Bernoulli equation, we derive the pressure gradient, which is 17 millimeters of mercury. Now, how is that done? The modified Bernoulli equation is the delta P, or the pressure gradient, in millimeters of mercury equals 4V squared, and V is the peak velocity in meters per second. This is a good approximation of pressure gradients. So, limitations of pressure gradients by MR. Well, first of all, it may be difficult to interrogate the peak. Secondly, the temporal resolution of MR may be lower than that of echocardiography, so we may not be as accurate. In addition, the threshold number that we use is somewhat arbitrary, whether we're going to use 15 millimeters of mercury or 20 millimeters of mercury. I don't know in any one particular patient what the threshold pressure gradient should be. However, another way of assessing functional significance in each individual patient, and again, we do this on an individual basis, is to measure collateral blood flow using the phase contrast technique, velocity-encoded cine MRI. This is a patient who had had coarctation repair in early childhood, and he came back to us as a teenager. We can see that there's no recoarctation, but we can measure blood flow in the proximal descending aorta just distal to the coarctation. We can see the flow curve indicated in yellow. And then we measure blood flow in the distal descending aorta as indicated in orange. And you can see there's a slight decrease from proximal to distal in the descending aorta. There's approximately a 4 to 7% decrease on average. And the reason it decreases is in the setting of no coarctation, there is blood flow away from the descending aorta via the intercostal arteries. So there's less blood flow in the distal portion of the descending aorta compared to the proximal descending aorta because some blood does flow out via the intercostal arteries. In the setting of a severe coarctation or a moderate coarctation with a hemodynamically significant stenosis, not much blood gets across the coarctation, and the pressure in the descending aorta is low. So there is reversal of flow in the intercostal arteries, which serve as collateral channels, and blood comes into the descending aorta. So the proximal blood flow is lower than that of the distal flow because blood is coming in. This is a patient with severe coarctation of the aorta, and the proximal blood flow, about 1 to 2 centimeters beyond the coarctation site, is depicted in yellow, and there's marked increase distally compared to proximally. So any increase is consistent with a hemodynamically significant coarctation. And in this patient, we quantified it, there was an 85% increase from proximal to distal, which is quite a significant amount of collateral blood flow. So any increase indicates hemodynamic significance, and the patient could benefit from intervention. In this study a few years ago, we showed that the collateral blood flow diminishes very quickly after coarctation repair. So you can see in yellow, this is the pre-procedure blood flow. Proximal blood flow was lower than the distal blood flow. You can see the distal blood flow here, the proximal blood flow here, and the collateral circulation here. Whereas post-procedure, the proximal and distal blood flow in orange was almost the same, and there was no collateral circulation. So this is another way to assess functional significance in these patients pre and post-procedure. So I'd like to conclude with a few take-home points. So in Tetralogy of Fallot, we evaluate patients with adult Tetralogy of Fallot post-operatively. We want to measure the right ventricular volume to assess for right ventricular enlargement. We quantify pulmonary regurgitation. We identify branch pulmonary artery stenosis, as well as myocardial fibrosis using delayed enhancement, which will help us determine prognosis. In transposition of the great arteries, we want to identify baffle patency or leak in patients who have had a mustard or setting procedure. Or in patients who have had the arterial switch Jatene procedure, we want to determine whether there's a pulmonary artery stenosis. And in coarctation of the aorta, we assess recoarctation, which occurs relatively commonly after repair. We also want to measure the functional significance by quantifying the collateral circulation, and in some cases we do pressure gradient measurements as well. So thank you for your attention.